I'm going to be talking to you about immunisation of the immunocompromised child. So this is an issue I think comes up a lot in terms of the extra need for these children to be getting vaccines, but also the extra complications of these children getting vaccines, that kind of central dilemma of sometimes it's the children that most need immunisations that either mightn't respond as well or might potentially be at risk of these vaccines. And they do require extra thought. This is something I think the NHS, we've heard this morning from Joe how good the NHS is at giving immunisations, and absolutely that's true for routine vaccines, and I think that's absolutely true. I think we're not very good at this because it falls out of the usual routine systems, and I'll show you some figures of that just at the end. So who are we talking about? We're talking either that children have immunodeficiencies, so what kind of things that we're seeing up here, or that have an increased risk of complications. So they are both kind of are linked, but have important differences between the two. Now you're all linked in with immunisation, so you know about the Green Book, but you'll also know that there are specific recommendations in the Green Book about immunisation of the immunocompromised child, and I'll be referring to those as we go along, and also deviating 1 or 2 points on some of the issues raised there. And also what I'll be talking about is also has input from American guidelines. These were produced in 2013 by the Infectious Disease Society of America. Some European guidelines for rheumatology, and there's also some study-specific ones such as CHIVA for HIV immunisation. So from a number of different sources, they've been pulled into a chapter that will be produced by the Royal College of Paediatrics in this blue book, which is being updated. There's going to be a chapter in that, and we'll be finalising some national guidance in the near future on this topic. But in general, immunocompromised children should receive all routinely recommended non-live vaccines, and they may be eligible for additional non-live vaccines. They may respond less well to vaccination than healthy children, so might need extra doses. If they're immunocompromised, the general rule of thumb is to avoid live vaccines, but there are some specific exceptions to that. And one of the things we often forget about is actually reducing their exposure, so paying increased attention to immunising family members in specific situations, especially things like Varicella Vaccine, for example. And on some occasions benefit from passive immunisation after exposure or in other specific situations. So in the Green Book, you'll be finding lists of things like this. The children who are at increased risk of pneumococcal vaccines, and the actual risks within here vary hugely. For example, for diabetes, there's not a huge increased risk for pneumococcal in those with diabetes. It might influence their diabetic control, but in others of those, such as chronic respiratory disease, are very much at increased risk, and especially if there's splenic dysfunction. So not all conditions are equal. But overall, if you took all of those kids, we've got a pointer, actually the proportion that cause disease, so we'll just look at this graph for a second. This is from a published paper. Number of cases in children 3 months to 5 years of age, in children with no comorbidity, so none of those groups I just talked about, still count for the vast majority of invasive pneumococcal disease. So most disease happens in healthy children for invasive pneumococcal disease. Between 2006 and 2010, this is obviously around or just at the time when PCV13 was being introduced. So this is slightly out of date, and this will change, but it is interesting to bear that in mind. So across this, actually about 15% occurred in children with comorbidities. What do those comorbidities consist of? About a third of them, if you look at this pie chart, were in children with immunodeficiencies, hematological malignancies or solid organ malignancies, or sickle cell disease. And about another third were in congenital heart disease or children with Down syndrome, and then another third with other conditions along these, very broadly along here. And that changes slightly when you get older children, so between 5 and 18 years, comorbidity comes up to about 30%. So it's a higher proportion there. And one thing about them is that children with comorbidities tend to have a broader range of conditions. For pneumococcal disease, especially we're talking about here, they have a broader range of serotypes. This is again around the time that PCV13 was being introduced. This is in healthy children, quite a limited number of serotypes, much greater spread, so harder to prevent through immunisation based on serotypes for children with comorbidities. And to just go onto this slide quickly, if you're looking at children with comorbidities, it's either if they're in dark grey or black, they're covered by one of the vaccines we're using. This is around 2010-11. About over a third of these were in vaccines not covered by the conjugate vaccines that are used at the moment. Whereas obviously a much higher proportion are related to the vaccine serotypes there. But of those children that had invasive pneumococcal disease, how did they receive all the vaccines recommended? Well, you'll be aware that there's a recommendation for these children that they get the polysaccharide vaccine, the 23-valent one. That recommendation is controversial. Do they get it or not, firstly, is the question. Of those that got disease, only about a quarter had actually received that vaccine. But when they looked for the risks, if they had the development of disease due to the 23 serotypes contained in that vaccine was not associated with whether or not they'd received that vaccine or not before. It's an indirect way of saying, a kind of backwards way of saying that this vaccine didn't seem to prevent them getting disease due to those serotypes. And there's a lot of evidence around this very controversial area as to whether that vaccine works or is effective in reducing disease. This is summarised in this article here, that they can respond in antibodies. There is actually a concern that actually repeat immunisation with this vaccine can blunt the immune response, both to subsequent doses of that vaccine and to the later dose of conjugate vaccines. The evidence for the effectiveness is not brilliant. So what are the recommendations for pneumococcal disease, for pneumococcal vaccines in children with immunodeficiencies or who have increased risk of disease? You may probably be familiar with this, but basically if they're under 2 months to 12 months of age, they get the routine schedule, 4 and 12 months of age. If they're at 12 months to 5 years of age, they should get then 2 doses with an interval of 2 doses between it. Okay, and that is for those that if they've got asplenia or splenic dysfunction or who are immunosuppressed. So if they've got any of these things, they should get 2 doses. Other children between 12 months and 5 years, if they haven't already had PCV13, should get 1 dose. And then if they're over 5 years of age, actually there's no recommendation. If you came across a 7-year-old who is immunocompromised and actually hadn't received the conjugate vaccine, there's no recommendation that they get this vaccine based on cost-effectiveness analysis, unless they're severely immunocompromised. Now, we'll come on to that in just a second, what's meant by there. There is also a recommendation for all of these groups that they get a dose of the polysaccharide vaccine, 23, over the age of 2. For severely immunocompromised here, this means if they were bone marrow transplant patients, leukemias, primary immunodeficiencies, then they should get PCV13, but otherwise not. Okay, so if you fall into those risk categories over the age of 5. Now, just for some specific examples, CHIVA, for example, HIV guidance, they say, oh, well, we want all our kids, if diagnosed with HIV at 9 years of age, not had a pneumococcal, we would like them to have pneumococcal conjugate vaccine. And they have actually specifically said that they do not believe in the use of the polysaccharide vaccine for that disease group, which is interesting. And certainly that's our local guidelines as well, that we don't recommend. So that's pneumococcal disease, just quickly. Meningococcal disease, you're very specifically increased risk of pneumococcal disease if you lack a spleen. You're very specifically increased risk of meningococcal disease if your complement system isn't in working order. That's another arm of the immune system. This amazing electron micrograph shows a hole being punched in the membrane of the meningococcus, which is formed by the complement membrane attack complex, which is part of the complement cascade. If you can't do that, you're at increased risk of disease. This is the complement system. We're not going to go through that. But basically, if you lack the bits down here, the terminal complex, these ones here, you have a 7,000 to 10,000 times increased risk of meningococcal disease. This is not that common, but if you've got it, it's bad news for you. And about half of those children who've got that will get meningococcal disease. And they get repeated episodes of disease as well. So there's specific guidelines for them. I'll just skip this in the interest of time. And also for splenic dysfunction, they have specific guidance. We don't actually have good data yet on how well those children with complement deficiencies or lacking spleens respond to the MenB vaccine, but that study is ongoing at the moment, or it's just been completed, and we'll be getting that data soon, we hope. This is the routine recommendation for healthy children for the MenB vaccines. But what I'll just run through is this quite useful summary that's in the Green Book, talking about what they suggest. If you've got any of these conditions, lacking a spleen or complement deficiency, this is their they run through at different age groups what they would be recommending. For example, if you're under 6 months, you get the MenB at 2, 3 and 4 months, and the ACWY, quadrivalent, 2 and 4 months. Booster dose with Hib, Men-C and Pneumo at 12 months, and goes from there. And it does this for each of the different age groups as to what they were doing, a kind of practical guide as to how to get the MenB, Men-ACW and PCV13 into children in these conditions at different ages of diagnosis. At 6 to 11 months, they always suggest an extra dose of Hib Men-C. It's important to be aware of that for all these conditions. They do suggest an extra dose of Hib Men-C to be mindful. And there we go on. Okay, so that's just extra vaccines for children at increased risk of pneumococcal and meningococcal disease, and that, for those ones. One of the questions that often comes through to Vaxline, I believe, is regarding live vaccines and their use in children with immunocompromised. And when we're talking about live vaccines, these are the ones we're usually talking about. So, firstly, to say in immunocompromised children, not all immunodeficiencies are equal, and we're much less concerned with live vaccines. We're actually not concerned about lacking a spleen or complement deficiency. You cope fine with live vaccines in that situation, or with the minor antibody deficiencies. Really talking about children that have got a primary immunodeficiency in these groups here with the B and T cell function, and or those that are on acquired immunodeficiencies, for example, from HIV, or if they're commonly, these groups here, these are the ones we get most questions about, I believe. And even with HIV infection, for example, not all HIV infection is equal, because if you actually have HIV but are well treated on antiretrovirals and your CD4 count is adequate, then you're okay. But if your CD4 count is under 15%, then you are severely immunocompromised. And all medication, immunosuppressive medication, isn't equal. And this is defined in the European guidelines I talked about earlier as to what is high dose versus low dose immunosuppressive therapy. So, high dose, for example, a child on steroids, and that's a common scenario. If you've got nephrotic syndrome and many other different conditions. Actually, the condition is if you've been on this dose of steroids for more than 2 weeks, that's considered high dose. Anything under that is considered low dose. Whole range of different medications here and doses recommended. One specific one that's used in children with Crohn's disease, sulfasalazine, is included on this list, but actually when you look at the data, it isn't actually an immunosuppressive, and live vaccines are safe with that particular medication. There's a whole new range of immunosuppressive therapies called biological agents, which you can see down here, is usually ending in MABs for monoclonal antibodies. They're all considered high-dose immunosuppressive, and you avoid live vaccines in that situation. So you avoid live vaccines in any child with high-dose immunosuppressive therapy and severe immunosuppression from HIV. That's straightforward. Some specific vaccines to consider, though. What about rotavirus? We give very early on. And sometimes before we know a child has an immunodeficiency. The usual apple age limits, of course, apply, so you want to get it in early. And we know to avoid it in SCID, severe combined immunodeficiency. And broadly otherwise, the guideline says that we're not sure about the safety and efficacy in other immunocompromising illnesses, but it's probably okay because they're all going to get rotavirus anyway. We know that these kids will be exposed to rotavirus, full stop, unless they're in a bubble, they will be getting rotavirus, so you may as well give them the vaccine, is broadly what the recommendation is. And it can be given in neonatal units, is the recommendation. That changes, there are some neonatal units that have reservations about doing that, but broadly advises that's okay to do that. Just some specific data. There was a study looking at giving the rotavirus vaccine to 100 HIV-positive South African infants, and you can see their adverse events rates are along here, which were very similar to for those with disease versus controls. And also they made an excellent immune response in this situation. Okay, so actually, sorry, this is actually comparing the vaccine versus placebo here, and specific reactions but the vaccine was broadly well tolerated. And so the CHIVA guidelines for HIV do actually recommend giving rotavirus vaccines, as per with other children. For BCG, another live vaccine, it's quite clear to not administer it to immunocompromised children, and also for the groups that we've been talking about earlier, and to withhold it from children with suspected or confirmed HIV. But to definitely do give it to HIV-negative children of HIV-positive mothers, because there's an increased risk of exposure to TB. So if a child is confirmed as being HIV-negative, then it's appropriate to give them BCG if their mother is HIV-positive. Varicella vaccine, another live vaccine we don't recommend routinely here, and so this is especially relevant because unlike in, for example, in America or Australia where they're routinely giving varicella vaccines and community exposure is reduced, all children are being exposed to chickenpox at some point in their childhood, more or less. And we know that, for example, in children with HIV, their risk of getting severe varicella is much higher than in other children. So even if you're HIV positive on treatment, then your relative risk of being hospitalised for varicella is 15 times that of other healthy children. So could we give them the varicella vaccine? It is a live vaccine which does establish a latent infection in the body which is susceptible to acyclovir, and that's relevant. So if you were to get a breakthrough infection, you can treat it, and that's worth bearing in mind. We do get ongoing exposure in the UK to varicella. So could we give it to, for example, HIV-positive children? We've just said they're at increased risk of disease. Studies have looked at this and found that actually it works. So against chickenpox, 82% effectiveness. Against shingles, 100% effectiveness. And actually getting the vaccine didn't affect their CD4 count. And so the CHIVA guidelines are that it is appropriate to give children with HIV varicella vaccine. So we're starting to break down this kind of dogma of not all, that it is okay for some live vaccines to be given to some children with immunodeficiencies. Broadly, that we're very careful and we don't give them, but there are some specific situations where it's okay. And interestingly, and the rheumatologist, the bane of their life is the Friday afternoon call of the child that's on high-dose immunosuppressants who's been exposed to chickenpox in their playground. And they have to bring them in and give them Zig, or some sites give them acyclovir. And they keep coming back to, can we give children on low-dose immunosuppressants, when their therapy is being tapered down, they're on low-dose immunosuppressive, can we give them varicella vaccine? And how will they go with that? There's not adequate information yet. But this is a small study done on 25 children with inflammatory rheumatological conditions, all on different medications, some at quite high doses, and giving them the varicella vaccine, and broadly they coped very well with it. You can see here, the first sign of not coping well with the varicella vaccine would be if you get a breakthrough rash, and that was seen in only a small minority of these children. And they did amount to a good immune response, and actually after 2 or 3 follow-up, only 2 out of 25 of those children had developed chickenpox. There's really not adequate data yet. I know that some rheumatology centres are recommending varicella vaccine for these children, but we're still in an area of uncertainty with this, I think. Okay, I'll skip through because I realise that we've got lunch waiting for us now. So in terms of measles and MMR, another live vaccine, at least exposure is reduced. Although it's not optimal immunisation uptake, circulation is, rates are low in this country. For those with acquired immunodeficiencies such as HIV, you can give it as per varicella, you can give it as long as their CD4 count is adequate. And for those on immunosuppressive therapy, most will have already had MMR as a child before they do it, and you can give a booster dose unless they're on high-dose treatment. But you should avoid in all primary immunodeficiencies, as you see here. The flu vaccine caused a lot of issues last year because, again, it's a live vaccine, the intranasal flu vaccine, and we got lots of queries about this. Annual flu vaccine is recommended for those children who are immunocompromised and at risk. Usually, we would recommend giving the inactivated flu vaccine for those on high-dose immunosuppressants, those on chemotherapy, and those with T or B cell immunocompromised. So we do have the choice here, at least, of inactivated or the live intranasal vaccine. But we would suggest that the live vaccine is not contraindicated for those over 2 years of age with stable HIV infection and low-dose systemic corticosteroids or just inhaled corticosteroids. But the key thing is to try and encourage immunisation of household contacts, and that those household contacts can mostly get the live attenuated vaccine, and unless for severely immunocompromised hosts. So if there's somebody with a severely immunocompromised, such as a hematological malignancy, or immunosuppression, primary immunodeficiency, then those household contacts should get the inactivated vaccine, but otherwise live is fine. Okay, for those who have had chemotherapy, and this is where we really do fall down in terms of repeat immunisation after chemotherapy, we should be giving, recommendation is for PCV13 for all those with hematological malignancy if they've not had it before, giving the inactivated flu vaccine from the age of 6 months. And then after they've completed their chemotherapy, 6 months after for routine chemotherapy, give a booster dose of all routine vaccines. And for bone marrow transplant, we actually repeat the immunisation schedule as outlined here. We audited this quickly, and actually in Oxford, and actually found pretty low uptake. And this is really disconcerting. This is to look at those that have got their extra vaccine, their booster dose after immunisation. And this was down to around, at best, 60% got their extra dose of vaccine. For some of them, such as pneumococcal, for which is at a definite increased risk, less than 1 in 5 had actually received that recommended booster dose of vaccine. We do not do this well. And this is other data which shows that this is just not an Oxford phenomenon, but shows that it is actually a widespread phenomenon, that booster doses post-chemotherapy and post-bone marrow transplant are not done well. Unfortunately, the uptake's very low. So just to summarise that, these children should receive all routinely recommended non-live vaccines and may be eligible for some additional ones, such as extra doses of pneumo, MenB, Hib. They may respond less well. We can consider live vaccine only in some very specific situations. In general, if they're on high-dose immunosuppressants, avoid live vaccines. And we can go from there. But importantly, no vaccine works when it's sitting on the shelf, and so we actually have to make sure that we're giving these things.
Very good.
Thank you very much.